Okay, well, welcome. My name is Katie Morgan. I'm in Charleston, South Carolina, and I want to welcome you to this evening's webinar for the SSAT. We have four fantastic abstracts for presentation tonight and are looking forward to the discussion. So with that, we'll get started with our first abstract, which it comes to us from Marshall University, as well as Case Western. It's going to be presented by Dr. Abdelmasseh. It's value assessment for patients who underwent minimally invasive versus open colectomies at a tertiary medical center. Thank you. You want to go ahead, Dr. Abdelmasseh?
Good evening. So good evening, ladies and gentlemen. First of all, I'd like to thank the committee for giving me such an opportunity to discuss our study on the value assessment for patients who underwent minimally invasive versus open colectomies at the tertiary medical center. It's a 10-year study. We have nothing to disclose. It is estimated that more than 300,000 colectomies will be performed in USA in 2020. At an estimated average cost of $60,000 to $70,000 for a non-complicated case. Nowadays, healthcare policies are assessing the value to determine schemes connecting reimbursement to performance. Our main objective, our primary one, was to define a baseline value of colorectal procedures before the introduction of enhanced recovery after surgery of protocols for all types of colorectal procedures, like laparoscopic, robotic-assisted, and open. Our secondary endpoints were to determine variables that affect their cost and to determine variables that predict complications. We developed a database with predefined 81 clinical variables, and they were standardized through the study period. Our data was retrieved from Marshall Warehouse in a retrospective manner from January 2010 to July 2016, and prospectively from REDCap from August 2016 to December 2018 and 19. Our studies were performed under IRB-approved protocols. We assessed the value based on the equation value equal quality over cost, where the quality was assessed based on grading and recording complications using a standardized grading system for surgical complications. We gave the uncomplicated with no readmission cases 1 unit value. For grade 1 complications, 0.95, grade 2, 0.75, grade 3, 0.6, grade 4, 0.5, and grade 5, we gave that a 0 value, which represents death. For the cost, it was defined as total hospital charge for readmissions and admissions up to 30 days post-discharge and corrected for inflation of 5% APR. The unit value for uncomplicated robotic-assisted colectomy with no readmission and length of stay less than or equal 4 days was $68,048. We give that a value unit of 1. The statistical analyses were performed using MATLAB on 55 clinical variables. Univariate and multivariate analyses were performed by linear and logistic regression as fitted, and statistical significance was set at 0.05 level. 426 patients were included. 10 patients were excluded from the study because of a value and cost analysis because of not submitting the billing records. Outliers of value outside the range of plus or minus 3 standard deviation were excluded as well. Those were 14 patients. The mortality of, we had 13 mortalities of the study, which represents 3% of the whole population of the study. As for the study, we found that 55% of the population were females, ranging between 47% in open elective to 63% in laparoscopic elective and robotic assisted elective. Mean age was 61, mainly in most of the procedures. The main PMI was 30, ranging between 29 and 32. Main length of stay in days was 7.8, ranging between 5.4 in laparoscopic and robotic assisted to 10.8 in open emergency. Readmissions were ranging between 4% in robotic assisted to 12% in open elective, and the mean was 9%. The mean cost was nearly $106,000, and the mean value was 0.76, ranging between the least of 0.68 in open emergency procedures to 0.83 in laparoscopic elective procedures. When comparing the types of complicated procedures to the year procedure, we found that in the retrospective data from January 2010 to July 2016, we found that 90% of all the robotic assisted colectomies were complicated. We had the same percentage in prospective data. For laparoscopic colectomies, 24% were complicated, whereas 17% in prospective data. Complicated open colectomies, we had 40% in retrospective data were complicated, where it is 33% in prospective. The most of which we have is the emergency open colectomies. We had 50% complicated in the prospective, whereas it's 39% in the retrospective ones. And for the elective ones, elective open, it was 40% versus 27% in the prospective. Comparing the number of patients with postoperative complications by type of procedure, we found that 78% of all the laparoscopic colectomies were of no complications or complications of grade 1, is electrolyte imbalance. While in elective open colectomies, 65% was the same case of no complications or grade 1 complications. On the other hand, it's 35% of complications grade 2 or more, with 7 death mortality, which is 3% of the population for elective open colectomies. In emergency, the percentages were different. It was 54% with no complications or complications of grade 1, 46% of complications of grade 2 or more, with 10% mortality rate. Robotic assisted colectomies, 80% with no complications or complications of grade 1, and only 20% of complications 2 or higher. When assessing the value of colectomies by type of procedure and the cost of colectomies by type of procedure, we included the patients in the uncomplicated procedures to be all the patients with no complications or grade 1 complications of electrolyte imbalance. And we find that uncomplicated versus complicated differ significantly in cost and value, but they didn't differ by type of procedure. We did extra analysis on comparing the value of complicated elective, open, laparoscopic, and robotic assisted colectomies and comparing the cost of complicated elective, open, and robotic assisted and laparoscopic colectomies as well. We found the same, there's no big difference between the procedures. When we did the univariate analysis, we found that the variables that predict complications after colectomy, for complications grades 1 and 2, they were age, diabetes, and type of procedure. Specifically, the right side procedure versus the left. It was less in the right side. For complications grades 3 and 4, the age, specifically more than 65 years, comorbidities of diabetes and end-stage renal disease, ASA class, and surgeon were predictive. Whereas in complications grade 5, which represents the death, age, preoperative diagnosis, and type of surgery were predicted. In multivariate analysis, we found the variables that affect cost after colectomy to be type of procedure, age, preoperative diagnosis, ASA class, comorbidities of diabetes and end-stage renal disease, length of stay, and complications. Whereas the variables that affect the complications after colectomy, they were type of procedure, age, preoperative diagnosis, ASA class, and diabetes. In conclusion, in our tertiary medical center, there was no significant difference in cost and value between elective type of colectomies, laparoscopic, open, or robotic-assisted colectomies. Variables of type of procedure, age, preoperative diagnosis, ASA class, comorbidities of diabetes and end-stage renal disease, length of stay, and complications have a significant effect on the cost of procedures. Whereas complications can be significantly affected by type of procedure, age, preoperative diagnosis, and AS class, and diabetes only. Right now, randomized controlled trials will be developed to decrease the rate of complications and improve value of colectomies in our healthcare system. And thank you.
Great, thank you so much, Dr. Abdelmasseh. We will open our discussion with Dr. Emre Gorgun from Cleveland, Ohio. I first want to remind people that there is the ability to ask questions or to submit questions through the platform. So if you have questions on the Q&A, please submit them and I'll help ask them for you. Thank you, Dr. Gorgun, for discussing the paper.
Thank you very much, Dr. Morgan, for the kind invitation, and I thank you, the authors, as well for their work and sending me their presentation in advance. The goals and the study question is very timely, especially in this day and age where the penetration of minimally invasive surgery is rapidly increasing. However, potential added or operative costs can be deceiving and is a burden for adaptation of the minimally invasive surgery. Thus, searching for true objective value of minimally invasive approaches in colorectal surgery is imperative. So in that regard, I have the following questions for your presentation. In your series, you reported a mortality rate of 3%. And this seems higher than national average, which is, we know that, less than 1%. So if you could please elaborate on this, I would appreciate it. And similarly, in your series, again, more than 50% of your patients had open colectomies. This is also a fairly high number. And is this due to lack of training or experience at your center? Are there attempts to improve MIS services to your patients in your center? Especially since you also demonstrated, as we listen in your conclusion, there's no difference between different type of colectomies, whether it's MIS, open, or robotic. Do you think the results of the study will serve and support for more surgeons to do minimally invasive surgery, or in contrary, this will be a basis that if there are no added value or cost, if there's no difference, is that gonna support open surgeons to continue to their practice? I would like to certainly get what's the take-home message based on the study. Do you believe that the results of the study supports then not necessarily increasing the penetration of minimally invasive surgery, or not necessarily supporting the role of minimally invasive surgery? And should we all go back to our approach to do open surgeries? I can, if you can help me understand that, I would really appreciate it. And thank you again for this nice presentation, and looking forward to reviewing your manuscript.
Perfect. Thank you, Dr. Gorgun, for reviewing the presentation, and thank you for the question. Those are like very great questions. So for the first question about the mortality rate, it's 3% of the whole population from 2010 to 2010. It's like 10 years. In our database, most of the robotic assisted and minimally invasive, which has the least complications, were of the prospective data. But before that, we had the rate of mortality were higher in the retrospective part. Answering the second question that you mentioned about which is better or which is the recommended procedures, I would say the minimally invasive, although there is no much of difference between cost and value, it is there is a big difference in other variables like length of stay and rate of complications. So minimally invasive procedures are getting higher in the choice of this kind of procedure against the open ones. In this area, the take-home message, we try to figure out the variables that predict the baseline for the predictions of what variables do we have that can affect the value, so we can build up our clinical trials for this. And we found many of them, like the length of stay, the diabetes, these kind of things. And we are building randomized clinical trials for this in order to overcome these variables and get the highest value of it.
Very good. One more question I can ask you based on your answer. You also like determining new variables to have strategies moving forward. Also, one of the goals mentioning that was to implement the ERAS protocol. How is the results of your study gonna affect the implementation and introduction of ERAS in your center?
So for this study, when we got the variables like length of stay and this kind of thing, so we implemented the ERAS to have like the clinical trials of getting the different procedures in the randomized controlled trials. We get the patients for elective procedures, and we get them for the glucose levels and colon preparations, and we compare that between that and other procedures in the ERAS area. So we are spotting a light on the variables that affect the cost and value in this area.
Great, thank you. In the interest of trying to stay on time, we've got a few questions from the audience. I just want to, maybe I'll combine them. One quick question is, did you specifically look at abdominal wall complications in hernias? Obviously, that's an advantage of minimally invasive approach versus open. And then a second question is, it combines all the other questions, which are based on how you decided to assign your rate of value based on complications, and whether you know how you did cost. Although I read from the abstract that maybe it was based on charges, just to confirm.
That's right. So those are very good questions as well. So for the first one, I'll start from the last one about the charges and the value. So we use the value equation, value equal quality over cost. The cost was all the hospital charge, not the price of the surgery or the length or the stay, or it's just the hospital charge for 30 days post discharge for all the 30 days, and it was corrected by 5% APR. For the second question about I'm sorry, remind me of the first question again.
Specifically asking about abdominal wall complications.
Right.
So that's the advantage, or an advantage of minimally invasive surgery.
Right, thank you. So this project was about many or multiple procedures. Like for this one, it was colectomies. We're working on hernias. We're working on cholecystectomies and appendectomies as well. And we are predicting the value and the cost, or the variables that affect the value and the cost in each surgery. So right now in this colon resections study, we do have the results. We're working on hernias for the future.
Great, thank you so much, and congratulations on your study. We look forward to more great work in the future.
Thanks.
And so now I'll move on to our next abstract, which comes to us from Indiana University. It's going to be presented by Dr. Alexandra Roch, and this is portal vein thrombosis after venous reconstruction during pancreatectomy, timing and risks.
Good evening. Good evening. I would like to thank the SSAT for the webinar, for the opportunity to present our work today. I have nothing to disclose. Due to the close anatomical relationship between the superior mesenteric vein or the portal vein and the posterior neck of the pancreas, venous involvement during by a tumor or by inflammatory adhesions is not uncommon. So historically, portal vein involvement was considered a sign of advanced and unresectable disease. Fortner in 1984 was the first one to actually describe what he called regional pancreatectomy with en bloc resection of the portal vein regardless of venous involvement. So that didn't last long, and that was soon abandoned due to a significant increase in mortality and morbidity and no real benefit in survival. From the 80s to the year 2000, there was a lot of studies trying to refine the need for portal vein resection during pancreatectomy, whether it was the Ishikawa classification in '92, defining the indication for portal vein resection, to '96 with the study from Behrman confirming that portal vein resection was actually a safe procedure. All this work finally led to the expert consensus recommendation from Evans and colleagues in 2009, confirming that venous resection was actually the standard of care to achieve negative margin resection. So if we classify the indications for portal vein resection, there are four categories. In most cases, portal vein resection can be planned preoperatively on cross-sectional imaging studies. However, in a minority of patients, portal vein resection is unplanned and it's due to an intraoperative venous injury. Portal vein resection can also be performed for benign disease with significant posterior inflammatory adhesions, whether it's pancreatitis, pseudocyst, or cystic lesions, or it can be performed for pancreatic cancer, and it's defined by the 2020 NCCN guidelines for borderline resectable pancreatic adenocarcinoma. So why is it so important to study portal vein resection and reconstruction? It is safe in most high volume institutions. However, portal vein thrombosis following reconstruction has been described in up to 30% of patients. Although most patients are going to be asymptomatic from it, whether it's in the acute or chronic phase, the major complication is a long-term risk of portal hypertension and liver failure. Just as a reminder, I've put the clinical features of portal hypertension on that right side. So as the risk of superior mesenteric or portal vein thrombosis after resection and reconstruction during pancreatectomy remains unclear, the study aimed to describe the prevalence and risk factors of portal vein thrombosis. From 2007 to 2019, at a single academic institution, all consecutive patients who underwent portal vein resection during pancreatectomy were included in this study. We considered the primary outcome as the prevalence of postoperative portal vein thrombosis. The secondary outcome was the evaluation of the risk factors associated with development of post-op thrombosis. And we used standard statistics, univariate, multivariate, and Kaplan-Meier curves for patency. So there were really 4 types of portal vein reconstructions that were routinely used. It was either a venography or patch repair. It could have been a primary end-to-end anastomosis, or it can be the use of graft, whether it was an autologous vein graft or a prosthetic interposition graft. Of the 2,700 patients who underwent pancreatic resection during the study period, 220 had portal vein resection. The sex ratio was close to 1. The mean age was 65 years. Median follow-up was 175 days. Malignancy was the main indication for surgery in 92% of patients. 8% had benign disease. And the most common surgery was pancreatoduodenectomy in 82% of patients. Of the 222 patients with portal vein resection, 16% developed a thrombus postoperatively after a median of 15 days. And interestingly, 6% actually developed the thrombosis within the first week post-op. Just some operative outcomes. The median operative time for the entire cohort was 381 minutes with a median EBL of 800 cc. The median club time for reconstruction was 21 minutes. The mortality, once again, for the entire population was 6.8% with a morbidity of 47% and a median length of stay of 9 days. So venography was performed in 18% of the population. Primary end-to-end anastomosis was, as expected, the most frequently used in 65%. Autologous vein was used in 14%, and when it was used, it was most likely internal jugular in 29 out of the 31 patients. Splenic vein was used twice. When a prosthetic interposition graft was used in the 3% of patients, it was either a cadaveric vein, a bovine carotid, or more likely a PTFE graft. As expected, the median claim time was longer for a graft than for a venography or primary anastomosis. It was statistically significant. The rates of thrombosis were vastly different depending on the type of reconstruction, varying from 13% for venography and end-to-end anastomosis to 23% for an autologous vein repair, or 83% for a synthetic graft. So just 2 Kaplan-Meier curve for the patency outcomes. So the one on the left side is the overall population. The results were pretty good with 93% patency at 1 month, 89% at 3 months. When we divided it by reconstruction type, we found that graft repair was statistically significantly associated with poor outcome in terms of patency. And this is the orange curve, the one with the least good patency. So what were the outcomes associated with thrombosis? As expected, patients with portal vein thrombosis postoperatively had a significantly higher mortality, overall complications, and a longer length of stay. However, it was not statistically significant in multivariate analysis. Now we studied the predictors of thrombosis on the multivariate analysis. I haven't put all the factors that we studied. I've just put the ones that were either significant or that were interesting to discuss. So interestingly, neoadjuvant chemo, the OR duration time, the type of reconstruction, as I've discussed before, the clamp time, the pathology confirming vein invasion, or the type of resection margin were not statistically significant in either univariate or multivariate analysis. Interestingly, the anticoagulation type postoperatively, whether it was a vitamin K antagonist, an antiplatelet, or both, did not affect the risk of thrombosis in those patients. Similarly, postoperative fistula was not an independent risk factor for thrombosis, but what we found was interesting is that patients with post-op sepsis were more likely to develop thrombosis, and the relative risk was 4.5. In summary, in this series of 220 pancreatectomies with portal vein resection, 16% of patients develop a thrombosis postoperatively at a median time of 15 days. Reconstruction with interposition graft carries the high risk for thrombosis, and post-op sepsis is an independent risk factor for portal vein thrombosis with a relative risk of 4.5. In conclusion, this series suggests that portal vein thrombosis after portal vein resection during pancreatectomy is a common complication. Primary repair should be attempted first and be done whenever feasible, and the use of interposition grafts should be weighed against the higher risk of post-operative thrombosis. The prevalence of portal vein thrombosis is significantly higher in patients with post-op sepsis, and physicians should have a low threshold of suspicion even in asymptomatic patients. Thank you. I'll be happy to take any questions.
Thank you, Alex. Very nicely presented. An interesting study. Our discussion will be begun with Dr. Steve Behrman from Memphis, Tennessee. I'll remind you again to please submit your questions to the Q&A tab if you have some. Steve, thank you.
Thank you, Katie. Can you hear me?
I sure can.
Okay, good. I'm sorry I'm having technical difficulties here. Alex, nice presentation. I am pleased to see this paper chosen for the plenary session as it proves the power of a single institution retrospective review of one's experience in the management of a difficult surgical problem that offers solutions to improve perioperative care. The details contained within this well-scrutinized presentation by a team of seasoned pancreatic surgeons will help us provide better care for our patients with pancreatic cancer going forward, particularly as we push the boundaries of resection for borderline and locally advanced pancreatic cancer. These are the fine nuances that cannot be captured in a national database and lessons learned that often prove superior to those captured in a randomized controlled trial. I was particularly interested in this study because though I have had many grafts that looked perfect after construction, I was dismayed to find postoperatively that some went down. I have the following questions. 1, how often was the splenic vein ligated in those with graft thrombosis? And do you feel this had an impact on patency rates on segmental resections or even lateral buprenorrhees? Number 2, did you have a standard postoperative regimen following vein resection regarding antiplatelet or anticoagulant therapy, or was this surgeon preference? Do you feel these adjuncts are important following vein repair? Number 3, I think there is a difference between preoperatively planned or even intraoperatively unplanned resection as opposed to an intraoperative injury of the vein that requires vein resection. That is likely associated with more blood loss and a rattled surgeon, if you would. Do you have any data on the number of patients with an intraoperative injury and the difference in patency rates between that group and the balance of those with vein thrombosis? Was sepsis more common in those with an intraoperative injury? And lastly, sepsis occurred in 25% of those with graft loss, but only 14% had a postoperative pancreatic fistula. What was the septic focus in the remainder of those patients? I appreciate the opportunity to review this fine work and thank the Society for the opportunity to do so.
Dr. Behrman, thank you so much for reviewing our study and for very interesting questions. So I don't have all the answers, but I'll do my best. So how often was the splenic vein ligated? So in the group with thrombosis, it was between 45 and 50%. I don't have the data for the patients without thrombosis, but whenever it was feasible to keep the splenic vein patent, it was done. So we discussed that technical detail in our group too, and it will be added to the manuscript because just like you, we feel that that may actually impact the rate of thrombosis. Regarding your second question, so the post-op anticoagulation versus antiplatelet or even both was really a surgeon preference. We don't have an institution regimen. personally feel that like any vascular resection, they should be anticoagulated. But once again, we proved that whether it was antiplatelets, anti-vitamin K, there was really no difference. So I just think that they need some sort of anticoagulation post-op. Your third question, it's a very small number of patients that actually were done unplanned in the OR, and maybe just a handful. I don't have the numbers, and I'm not sure that it's going to be enough to actually plug into any type of multivariate analysis, but we'll definitely look into it. As for your question about sepsis, so the remaining patients had either an intra-abdominal abscess that needed to be drained, or had bacteremia from, what I remember was a UTI, a C. diff, a central line infection, I think. And so those were, all those patients were bacteremic in some sort, but the source was highly variable.
Great, thank you. You know, Dr. Behrman, you're so thorough. I think you really covered most of the questions that came through in our Q&A. So I think in the interest of time, we'll move forward. And congratulations so much, Alex and the group at Indiana, for a beautiful study.
Thank you.
Our next abstract comes to us from VCU, from Virginia Commonwealth University. This is gastric bypass increases circulating bile acids and activates hepatic FARNESOID X receptor that requires intact peroxisome proliferator-activated receptor alpha signaling to reduce liver fat content. It'll be presented by Dr. Guillermo Mazzini.
Good evening. Good evening. I'd like to thank for this opportunity. So these are my disclosures. I don't have conflict of interest. So weight loss is the staple treatment for NAFLD and NASH. And these two clinical studies published in Gastroenterology demonstrate that. The one on the left shows a significant correlation between percentage of weight loss and NASH resolution through lifestyle modification. And the study on the right shows how bariatric surgery significantly resolves NASH and improves percentage of steatosis. Importantly, NASH resolution rate was 25% with lifestyle modifications and 92% with gastric bypass. These improved results with bariatric surgery are likely related to a greater and sustained weight loss. However, surgery is suspected to provide for metabolic mechanisms that bolster fat mass loss. One of these mechanisms are the changes in circulating bile acid pools and species that have been shown to be increased after gastric bypass and duodenal switch. Those changes are observed after low-calorie diet. It's important to notice that that bile acids exert their metabolic effect by activating specific receptors, such as the FXR. FXR activation in liver enhances liver lipid metabolism by inhibiting lipogenesis and activating lipolysis. Another important regulator of lipid metabolism in liver is the PPAR-alpha. In liver, PPAR-alpha promotes lipid oxidation, inhibits lipid synthesis, and inhibits inflammation. And lastly, FXR can activate PPAR-alpha, leading to a possible synergistic effect in liver lipid metabolism. So as a consequence, FXR and PPAR-alpha may have a central role in NAFLD and NASH improvement after surgery. We previously presented at DDW and published in JOGS a study where we analyzed FXR and PPAR-alpha gene expression in human liver before and 1 year after gastric bypass or diet alone. And gastric bypass resulted in a greater NASH resolution rate, along with a concurrent increase in FXR and PPAR-alpha gene expression in liver. However, these are microarray data from a public repository, and we didn't have access to weight loss data, so we couldn't determine the cause and effect in our study. We have since developed a preclinical model of diet-induced obesity, NAFLD, and bariatric surgery in rats to study those mechanisms. This is what a gastric bypass looks in a rat. We can see the gastric pouch, the alimentary limb, and the biliopancreatic limb, pretty similar to what we have in humans. So we aim to study in rats with diet-induced obesity and NAFLD the effects of gastric bypass and low-calorie diet on weight changes, fasting bile acid levels, liver fat content, FXR, and PPAR-alpha gene expression in liver and their downstream targets. And we also aim to study the role of PPAR-alpha activation by inhibiting it after gastric bypass. So this is the study design. 24 male Wistar rats were fed a high-fat diet, and 8 rats were fed a regular chow for 12 weeks. At 12 weeks, all rats had a surgery, either a bypass or a sham operation. Obese rats were randomly assigned to one of 4 groups. The obese sham group had laparotomy and were kept on a high-fat diet. The gastric bypass group had a bypass and were kept on ad libitum regular chow. The pair-fed obese sham had laparotomy only and received the regular chow, but pair-fed to the gastric bypass group. And the last obese group had also a bypass and received ad libitum regular chow plus daily intraperitoneal injections of 2 milligrams per kilogram of GW6471, which is the PPAR-alpha inhibitor. The lean sham group had laparotomy and were kept on regular chow. All rats were followed for 7 weeks after surgery. After 7 weeks, the animals were sacrificed by isoflurane overdose after overnight fasting. Plasma were used for fasting bile acid levels measured by HPLC coupled to tendon mass spectrometry. Liver samples were kept in formalin were used for percentage of steatosis analyzed by histology on H&E staining. And liver samples that were snap frozen were used for triglyceride content measurement by colorimetry and for real-time qPCR for determining mRNA of FXR, PPAR-alpha, and the downstream targets SHP and CPT1. These results were analyzed by the delta-delta CT method, and the log fold changes were presented relative to the lean sham rats, which were defined as the reference group. Here we have the weekly weight changes throughout the study. After 12 weeks feeding period, the rats on a high-fat diet were significantly heavier. And at the end of the experiment, the obese sham group was significantly heavier than the other groups. It's important to notice that the bypass group, the bypass with the PPAR-alpha inhibitor and the pair-fed, they all lost the same amount of weight and they ended up with a similar weight and not different from the lean sham animals. This graphic shows systemic fasting total bile acid levels after surgery. There was an increase in fasting bile acid levels only in the bypass group without the PPAR-alpha inhibitor that were significantly higher than the obese and the pair-fed sham and similar to the lean sham animals. And here we have gene expression in liver, having the lean sham group as the reference group. There is an increase in FXR in SHP, only in the bypass group that you can see in red. And the FXR, both FXR and SHP were downregulated in the obese sham and the pair-fed sham animals. Also, PPAR-alpha activation PPAR-alpha was higher in PPAR-alpha activation and signaling, through CPT1A were significantly higher in the bypass group and were downregulated in the obese and pair-fed sham groups. These higher PPAR-alpha levels here in the obese sham group are secondary to the high-fat diet that those animals were receiving, but you can see that the signaling is downregulated just as the pair-fed sham group. This graphic presents percentage of liver steatosis. The gastric bypass animals had a significantly lower percentage of steatosis compared to the pair-fed sham and the obese sham, and similar to the lean sham group, as you can see here in the pictures, in the histology pictures. And it's similar to what we have for liver triglycerides content shown in this graphic, Gastric bypass and lean sham animals had significantly lower liver triglyceride levels in liver compared to the perfect sham and obese sham. We then compare the bypass groups with and without the PPAR-A inhibitor. And here we have hepatic steatosis and liver triglyceride content. Despite a similar weight loss between the two groups, there was a trend to a greater percentage of steatosis in the group with the PPAR-A inhibitor. And the liver triglycerides were significantly higher after PPAR-A inhibition. This slide shows fasting bile acids and gene expression in liver in gastric bypass with and without the PPAR-A inhibitor. The increase in circulating bile acids wasn't changed after PPAR-A inhibition, as well as the FXR activation in liver. We can see that PPAR-A and CPT1 genes are significantly lower in the bypass group receiving the drug, corroborating the effect of the inhibitor. And also this apparent increase in SHP is secondary to the PPAR-A inhibition due to a loop effect. So all these results point to PPAR-A activation after surgery as a key mechanism of NAFLD improvement. In conclusion, with similar weight loss, gastric bypass leads to a greater improvement in NAFLD when compared to pair-fed animals. Gastric bypass leads to a significant increase in fasting bile acid levels in plasma, associated with a concurrent increase in FXR in PPAR-A gene expression and signaling in liver that is not observed after similar weight loss through low-calorie diet. And when PPAR-A is inhibited in liver after bypass, NAFLD improvement is impaired despite a similar weight loss and preserved increase in circulating bile acid and liver FXR gene expression. That's why our results point to PPAR-A activation as a key mechanism in NAFLD improvement after gastric bypass. Thank you very much.
Very nicely presented, Dr. Mazzini. Thank you. So this discussion will open with the discussant, Dr. Eric Hsu from Boston, Massachusetts. And again, I'll remind you if you have any questions to submit through the Q&A tab.
Dr. Morgan for inviting me to participate in the session. And thank you, Dr. Mazzini, for really an excellent presentation. So really nice study that demonstrates once again that gastric bypass has significant metabolic actions that can occur separate and independent of weight loss. In this case, I think you've shown in a rat model that gastric bypass improves fatty liver disease and that this action might occur via signaling of the FXR bile receptor, bile acid receptor, and PPAR-alpha in the liver. I had a few questions for you. So first, I noticed you put your gastric bypass group on a regular diet post-operatively and transitioned them off the high-fat diet. And I'm guessing you chose this to mimic the clinical situation where we try to encourage a healthy diet in our patients post-operatively. But most animal studies usually maintain groups on the same diet, just to control for confounding effects of the diet itself, which has significant inflammatory and other physiologic effects in the intestine and the liver. So I'm wondering if you can comment how you think the differences in diet between your experimental groups affect your results. My second question is that your results sort of pointing toward PPAR-alpha as a critical pathway for NASH and fatty liver disease are definitely very intriguing. As you probably know, there's a class of drugs called the fibrates, characterized by gemfibrozol or fenofibrate. These are drugs we use for treatment of hypertriglyceridemia. And these drugs act as PPAR-alpha agonists. They've also been tested as therapies for fatty liver disease, and they haven't really panned out clinically. So I'm wondering how you reconcile sort of the lack of clinical efficacy of targeting this pathway for NASH with your findings in your study. And then the last question I have is that another sort of more commonly studied weight-independent effect of gastric bypass is on type 2 diabetes. And those in patients are linked to changes in liver, particularly hepatic insulin resistance in the liver. So I'm wondering if you've had an opportunity to look at some markers of diabetes in your model and the role of PPAR-alpha in those effects. So thank you again for letting me participate. Congratulations again on a great study, and look forward to all the great work from you and your group in the future.
Thank you very much for your comments and for revising our presentation. So the first question about the diet in the bypass group. So this is a key point of our study. You're right when you say that that might not account for the factors involved with the diet itself, but we wanted to make it like more mimic the clinical situation, but also our main goal here was to compare what happens after surgery to a low-calorie diet with the same degree of weight loss in the exactly same food intake. So that's very hard to do it in a clinical setting. So that's why we decided to switch the diet and have the pair-fed group as a low-calorie diet. And that made it possible for us to show that even losing the same amount of weight and eating the same food intake, the low-calorie diet led to only a mild improvement in NAFLD and kept the same gene expression and bile acid profile as the obese rats. So there's something there with the diet that is changing, or with the surgery, sorry. But we are now conducting a new experiment where we are also keeping bypass rats on a high-fat diet, so we can account for all those other confounding factors as we saw. For the second question, this is intriguing. This actually happens not only with PPAR-alpha agonists, but also with any other drug trying to improve NAFLD. Even the obeticholic acid that is the NAFXR agonist, it has a poor effect on NAFLD and NASH. So what we show here is actually that the bypass trigger metabolic mechanisms that probably goes through PPAR-alpha activation, and if we block it, we don't have the full effect of surgery. It actually doesn't mean that if we activate only PPAR-alpha, we'll have the same effect of surgery, because we don't have the whole mechanism being triggered. And probably that's why any of those drugs trying to mimic mechanisms described in bariatric surgery can have a full effect of the surgery, even for diabetes. And for the third question, and about insulin resistance, so this is a concept proven study. We didn't look at that. As I told you, for this our next experiment, we are just trying to integrate all the gene expression in different tissues with the metabolic features. But in humans, it has been demonstrated that PPAR-alpha is downregulated in NASH and in liver with NASH patients, and it is inversely negatively correlated with percentage of steatosis and negatively correlated with insulin resistance measured by the HOMA-IR. So yes, there is a point there. We know that obesity, liver fat deposition, and insulin resistance all impair PPAR-alpha functioning and downregulated in liver, and also triggering the more severe aspects of the NAFLD. But we'll hopefully we're bringing these questions in the next meeting with a new set of experiments. Thank you very much.
Thank you. Very nicely presented, and congratulations on that important work. Our next and final abstract comes to us from a multi-institutional group and will be presented by Dr. Clay Merritt from El Paso, Texas. And he's going to present to us development of a nomogram to predict individual benefit attained from the addition of adjuvant chemotherapy in the treatment of stage 2 colon cancer.
All right, thank you, Dr. Morgan. Let me try to share my screen here. There we go. Okay. So good evening, and thank you for the opportunity to present our research. We have no disclosures. So colon cancer continues to be a leading cause of cancer-related mortality in the United States. The NCCN provides evidence-based guidelines for the treatment of colon cancer. Stage 1 colon cancer is almost exclusively treated with surgery, while stage 3 disease is uniformly treated with surgery and adjuvant chemotherapy. Optimal treatment for stage 2 disease, however, continues to be debated. Older randomized controlled trials have failed to show significant survival advantage for stage 2 patients treated with adjuvant chemotherapy. Newer non-RCT data, however, have found that a subset of stage 2 patients, those with high-risk features of recurrence, may have a survival benefit when treated with adjuvant chemotherapy. Currently, there are limited data or tools to predict how much benefit stage 2 patients may receive from adjuvant chemotherapy. Our objectives were to first understand recent trends and drivers for adjuvant chemotherapy utilization in stage 2 patients, utilizing a national population-based data set, and then to examine the quantify prognostic high-risk features. Based on our identification of independent prognostic factors, we sought to create a clinical tool able to estimate the benefit of adjuvant chemotherapy in stage 2 colon cancer. Depicted here is our consort diagram. So we utilized the NCD database from 2004 to 2015. We identified all adult patients with stage 2 colon cancer. We then selected patients with primary colon adenocarcinoma, signet cell or mucinous histology. Patients treated with neoadjuvant therapy of any type were excluded, and only patients surviving 30 days after initial resection were retained. In total, we started with nearly 163,000 patients, and after exclusion criteria were applied, we ended with approximately 133,000 patients for analysis. We divided those 133,000 patients into 2 cohorts, those that received only surgery and those that received surgery followed by adjuvant chemotherapy. Multivariable logistic regression was used to identify independent factors for predicting chemotherapy use. Overall survival was assessed via the Kaplan-Meier method, followed by utilization of the multivariable Cox proportional hazards modeling to identify independent risk factors for death. Statistical significance was set at the standard p-value of 0.05, and we utilized our software for all analysis. So using our Cox Hazard modeling, we created a mortality risk score. This is a linear predictor utilizing the risk of 12 known and independent prognostic factors in colon cancer. The risk score is a number that denotes the patient's cumulative hazard or risk of death, and the higher the number, the more hazard or risk they have. Here are the basic demographics of our population. Compared to previous databank studies, our population was older, but still predominantly composed of white non-Hispanic patients. The study was fairly balanced with regard to gender, and most patients were healthy with a Charlson score of 0. Our analysis of trends and drivers for adjuvant chemotherapy use revealed older and sicker patients were significantly less likely to receive adjuvant chemotherapy. On the contrary, patients with T4 pathology were 4 times as likely to receive adjuvant chemotherapy compared to those with T3 disease, and several other well-known prognostic factors predicting of receiving adjuvant chemotherapy listed here on the screen. So survival analysis also revealed T4 tumor and an advanced comorbidity score to be the best predictors of a decreased survival, but the other listed factors were also statistically significant. Now for the factors that increased the chance of survival, most notably those stage 2 patients who received adjuvant chemotherapy were approximately 25% more likely to survive to 5 years after surgery than those that received surgical resection alone. Younger and female patients also had an increased survival. Our analysis revealed 12 independent prognostic factors associated with survival. All factors listed here, except for female gender, are significantly associated with decreased survival. Each of these 12 factors, along with their hazard ratio in parentheses, are listed. It is important to remember that age is a continuous variable, and though its hazard ratio here is low compared to the rest of the factors, it carries significantly more hazard as it increases. Shown here is a slight variation of the previous slide. These are the 12 prognostic variables that we did include in the final mortality risk score model. So on screen left is a scatter plot showing the cumulative risk needed before survival benefit from the addition of chemotherapy is seen. As the risk score increases beyond 3.34, the hazard ratio of adjuvant chemotherapy drops below 1, indicating a survival benefit associated with the addition of chemotherapy. Screen right shows the Kaplan-Meier curves for our population divided by risk score quartiles. The dotted lines represent patients that received adjuvant chemotherapy, and the solid lines represent those that did not. You can see that those who received adjuvant chemotherapy have better survival at nearly all time points, and that as the risk score increases, the survival benefit associated with chemotherapy also increases. And finally, here are the nomograms we constructed. All 12 previously discussed prognostic factors are represented. These nomograms can be used to predict mean 3, 5, and 10-year survival probability with and without chemotherapy use. The difference in survival estimates between the nomograms is the absolute survival benefit achieved with the addition of adjuvant chemotherapy. It is important to understand that these nomograms are shown are the pictorial representation of that mortality risk score that we discussed previously. Depicted here is the calibration curve for our nomograms. The graphs show an ideal calibration as the dotted line in the center of the graph. Good calibration is seen for 3, 5, and 10-year survival estimates. The discriminatory ability of the nomogram, or the C-index, is 0.70. Clinically, this means that 70% of the time, the nomogram is accurately predicting who will have a survival benefit if given adjuvant chemotherapy. So through our analysis, we found that all but the lowest risk stage 2 patients, those with risk scores less than 3.34, benefit from adjuvant chemotherapy. NCCN recommends considering adjuvant chemotherapy if one or more high-risk feature is present. Nearly 70% of our 133,000 patients had at least one high-risk feature. However, only 1/3 of those patients received chemotherapy. Having more than one high-risk feature did not significantly increase the chance of receiving chemotherapy. The graph shown depicts the stable and low percentage of stage 2 patients treated with adjuvant chemotherapy over the time period of our study. In reviewing other data, a new meta-analysis out this year concluded that all comers with stage 2 cancer and high-risk features saw a significant survival advantage with adjuvant chemotherapy. However, a subgroup analysis revealed that this benefit was attributable to certain high-risk features, namely T4 disease, suboptimal lymph node harvest, and intestinal perforation and obstruction. In comparison to this and other data on the topic, our nomograms allow for a better individualized risk assessment by considering up to 12 risk factors simultaneously. This cumulative risk assessment allows for accurate quantification of survival benefit if adjuvant chemotherapy were to be provided. We feel this risk assessment and survival estimate will significantly aid in the decision regarding adjuvant chemotherapy for stage 2 colon cancer patients. The limitations of our study include selection bias and incomplete data acquisition, namely failure of the database to capture several other well-known prognostic factors such as perforation, bowel obstruction, and several newer genetic markers to include KRAS and 18q loss. NCDB also has information about chemotherapy regimen utilized, but unfortunately it doesn't go beyond multi or single agent, so further specific analysis is not possible. And overall survival is recorded, but recurrence-free survival and other breakdowns are also not possible. We have only internally validated our risk score and nomograms, so external validation is clearly needed and encouraged. In conclusion, we have developed a risk score and nomograms that provide individualized survival estimates for stage 2 colon cancer and treated with or without adjuvant chemotherapy. Our analysis supports adjuvant chemotherapy use in stage 2 patients with a risk score greater than 3.34. A well-designed RCT is still needed to definitively answer this question of optimal treatment for stage 2 colon cancer patients. I thank you for your time and your attention.
Thank you so much, Dr. Merritt. And a very nice study. Our discussion will be begun by Dr. Ganai from Fargo, North Dakota.
Thank you, Dr. Merritt. I commend you for your paper using the National Cancer Database to develop a prognostic risk score and nomogram correlating with outcomes for stage 2 colon cancer. As you mentioned, this is a population where there's still uncertainty on added benefit gained from adjuvant chemotherapy, leading to this need to risk stratify our patient populations. Indeed, as practice changes towards routine microsatellite instability testing have become extremely helpful, as it is predictive of a disadvantage from receipt of 5-FU-based chemotherapy in the MSI high patient population. However, you note that there are other important predictors of risk that are of value to reconcile. So in looking at the details, thank you in advance for your paper that was provided for review. In looking at these details, I do have a few questions about your paper and the prognostic index. The first is, as you mentioned, the NCDB does not currently include recurrence data in their PUF file, only survival data. And so I would like your input if this is a limitation or a feature of value. Specifically, how is a mortality risk score different from a recurrence risk score, if at all? Second is that a large proportion of your patient population is missing data for MSI status, which is likely related to the time period included in your study. Did you address this missing data, given it's considered an important variable that is predictive of benefit from therapy? And if not, does this bias, or how does this bias your results? And third, you mentioned good calibration in the form of agreement between estimated and actual outcomes, as well as discrimination in the form of the ability of your nomogram to stratify risk levels apart. There's another term we sometimes use in discussing predictive modeling, and it's parsimony. Were the number of variables included just right or too many? And did you need to address this? And specifically, you mentioned that they're missing variables not available from the NCDB. What would you have rather liked to have also included? Thank you, and this is really important work.
Thank you for your questions, Dr. Ganai. So I'll start with the first one. So it is definitely a known limitation of NCDB to not break down the survival analysis beyond overall survival. We think that if this was captured in the NCDB, it would significantly aid in our study, namely because surviving with cancer and surviving without cancer is significantly different. And often, at least on most of the papers commenting on this subject, if you can break it down into a further analysis of disease-free survival, that's the ultimate goal. And the question is, are you curing these patients or are you just treating them? Without the recurrence data, it's hard to answer that question based on the NCDB database. So I do think it would add significantly. And if it comes out, we'd definitely add it to our study. For the next question, based on MSI status, there is actually a capture in the NCDB, as you're aware. However, as also commented on, its capture rate was quite low. And so we also feel that if this was able to be captured in higher percentages, we would add it to our nomogram, as it is an emerging factor that is prognostic and indicative of who will respond better to treatment and who will not. So we would also add that variable as well. Based on the calibration, whether it's too many variables or not enough variables, each of the variables that we included in our nomogram have been previously proven in other studies to be significant in their prognostic ability. So we don't think it was really too much or too less. We just went on the previous data to guide what to include in that analysis and nomogram creation, as long as the NCDB allowed it. And so as more and more factors come out, specifically these genetic factors, we would like to add them, especially if they are proven in other studies to be significantly prognostic. And for your final question, is there anything that we'd like to add? Obviously, I think one of the factors that I would be interested in is the perforation or obstruction at the time of diagnosis. That in the few studies that comment on that factor or those factors, they seem to be significantly, statistically significantly at least, to change the outcome of the patient. And unfortunately, though, there's only a few studies that comment on them, and then of those few studies, the patient numbers involved in those studies are quite low. Why it's not captured more, I don't know, but it's definitely not captured in NCDB. But in the studies that are there, it's a significant factor, and that one I think would be nice to know, because common sense would tell you it'd be kind of easy to include in the database, is the patient obstructed or not at the time of surgery, but maybe it's not as easy as I would believe. Thank you for your questions.
Great, thank you so much. Thank you to all the participants this evening. This was really a great session, and I appreciate everyone's attention. So we'll conclude. Thanks so much.
Thank you.